How is it? Good. Listen, I rarely read, I gotta get all this, I don't want to leave a thing out. So, born and raised in Ethiopia, and earned an undergraduate degree from Rosary College in River Forest, Illinois. She received her MD and JD at Southern Illinois University and a certificate in International Human Rights and Comparative Law at the University of Oxford. She completed her residency in Ob-Gyn at the University of Michigan, did her REI fellowship at the University of Michigan, joined the faculty and became the division director there. She also served as the medical director of the University of Michigan Center for Reproductive Medicine. She was the founding executive director of the Center for International Reproductive Health Training at the University of Michigan, which is a center that expands reproductive health services training for physicians, nurses, and midwives in sub-Saharan Africa. As a leader of the University of Michigan Ethiopia Collaborative Platform for Global Health, she's helped the University of Michigan forge strong partnerships with Ethiopia's Ministry of Health and St. Paul Hospital Millennium Medical College in Addis. She is serving as the director of the international programs at the Susan Thompson Buffett Foundation since 2015. And I gotta tell you, she is changing the world. And I want to say that our program in Ethiopia never would have happened without her. It was many years ago that Cynthia Watlett and I called up Senait and said, hey, Senait, we need some help here. Honestly, it was 10 years ago to be exact. And talk about generosity of spirit. With all she has going on, she took something over there, helped us form a bond with Hawassa. We would have nothing in Ethiopia going on without her. And I love what our program is doing. Methodical, programmatic growth. So with that, yeah!
Thank you so much for that very generous introduction, Laurel. I am enormously grateful to be here. I was coming, Rebecca Minter, the chair of surgery, is a longtime friend of mine, and so is Professor Gurman. And long ago I had committed to talk to them about global health, and they have been hammering me for many years to come and talk. As Laurel said, the last time I was here was about a couple of years after Laurel got here, when Cynthia Van Anderson and I and Laurel talked about global health and how important it was to address women's health and women's rights, irrespective of where a woman believes or where she's born and where she was raised. And that was sort of my contact to the University of Wisconsin. But I also had a very dear friend, a mentor, somebody who was a pain in the rear, but a remarkable teacher, Dan Max Lebovic, for those of you who've had the joy and pleasure of meeting him, who's probably one of the most outstanding teachers who has really shaped me and played a key role in me getting into reproductive endocrinology and fertility. So the Michigan-Wisconsin bond has been very strong. Yesterday I discovered almost the entire department of surgery as a Wolverine. We really had a great time. But when Laurel discovered that I was going to be here for a day, she asked me if I can come and talk to the students, medical students, residents, and faculty, and give grand rounds. I also got a little orientation about the sitting arrangement today, how the GYN oncologists and medical schools and generalists sit, so you guys are breaking code. So I also have my colleagues from Susan T. Buffett Foundation that have an incredible research program here. Maybe Tracy Callie, you can say hi to everyone. So we're really thrilled to be here. So thank you. So what I'm going to try and do in the next 45 minutes or so is go over the status of global women's health and what we think is going on, what we are observing, and how should we use our voices to address that. Unfortunately, I have a flight at 9 a.m. My colleagues in Michigan know that this is how I live my life, so I'm going to bolt out as soon as I finish. But Laurel and the department has my contact, and if any of you have any question or want to follow up on anything that I talked about today, or your amazing programs in Ethiopia. And if I can be of any help in any capacity, don't hesitate to reach out to me. So for those of you who follow the status of women globally outside of the United States, there were a 2019 report that came out on the state of sexual and reproductive health, and the UN Population Fund found that only globally, if you take, this is a population-based survey, only 57% of women around the world report being able to make their own choices, whether it's on sexual intercourse, contraceptive use, access to abortion, or in general make healthcare decisions, which is really discouraging. However, this is where Tracy oversees our US programs at the foundation, and I oversee our international program. And it has been such a confusing time, right? Like US, you all know what is happening, but if you look at what's happening globally, we are making progress in very unlikely places. Ireland, the most Catholic, more Catholic than the Pope, has changed laws on access to safe abortion and marriage equality. Rwanda, a country that has one of the most strictest abortion laws, that in fact, 2015 IPAS reported has jailed over 300 adolescents for seeking. In fact, they were caught coming to the facilities with post-abortion care, and they were jailed, and the president pardoned them for a crime that they should not have been jailed for to begin with, but just passed a law legalizing abortion with broad indication. And of course, the least likely is South Korea, who just struck out their anti-abortion law saying it's unconstitutional. So it is not all grim, but I think we have a lot of work to do. For me, for those of you that were at my talk yesterday, you may have seen this slide. This is little me trailing behind, in front of my older sister and next to my dad. And this defines who I am, right? So for me, it doesn't matter what I would have done in life, whether I was a physician, a nurse, a janitor, a pilot. I was raised by my father to just never take granted my status as a girl, as a woman in society for granted. I grew up in Ethiopia, where by most standards still is one of the poorest countries, where the value of a girl is really seen around her ability to deliver children and what things can she do to hold communities and contribute, whether it's fetching water or firewood, and not really looked at in terms of what is your ability to go get education and transform society. But I was really very fortunate to have a father who really believed in me and my ability to change the world. So irrespective of what field I would have gotten, I would have really been focused in not taking that basic right for granted. And I think a lot of us today don't pay attention to that, especially in this country. We really think women's rights, abortion rights, LGBT rights, all those things that don't happen to us personally is somebody else's problem. And I think we have found ourselves in this very precarious and just dangerous territory because we're always looking for someone else to solve that problem. And I think if you leave with anything today, I want you to remember that. I also want to give you a little overview of kind of the status and the challenge around the world. There are about close to 885 million women of reproductive age, so this does not include women who are younger and who are not married, or women in this age group that are not married. Unfortunately, the data that we have available due to culture, societal values, looks at only married women between ages 15 and 49 because supposedly they're the only ones who need contraception. So there are, out of this, about 214 million of them have unmet need for modern contraception. So these are women who are ready to use contraception but cannot access it. But if you say, where is the distribution of that, this will tell you. The majority of women who are trying to prevent unwanted pregnancy live in the developing part of the world, both lower middle income countries and particularly low-income countries, particularly sub-Saharan Africa. And this then is not too surprising. In addition to just the rights-based issue, you see the fact that the highest burden of maternal death, the highest burden of morbidity and mortality to pregnancy-related complications also tend to happen in this part of the world. There are about 6 countries, Nigeria, DRC, Ethiopia, India, Afghanistan, that contribute to about 50% of the maternal mortality in the world are in the 6 countries. So just in addition to the rights issue from basic healthcare access has an enormous enormous advantage in terms of improving health status. If you look at unsafe abortion, again, it's the same thing. There are about 25 million unsafe abortions that happen globally. And if you look at the distribution again, the majority, about 97% of this happen in the developing world. So it is not too surprising that it happens because the overwhelming need of disease burden, not just for women's health, but if you look at across spectrum, tends to aggregate in the poorest countries, and tragically, they are the least equipped to deal with it. So if you look at really burden of disease and workforce distribution as well as resources, here is a graph that will tell you the story. So this axis tells you the global health workforce distribution. Here is the global burden of disease, and the size of the bubbles tell you our financing and expenditure. So if you look at sub-Saharan Africa particularly, this is not inclusive of, the numbers include the disease burden. A lot of the contribution is from sub-Saharan Africa, has the highest burden of disease, whether it's maternal mortality, malaria, TB, HIV, rising non-communicable diseases. Our alcohol, beer, tobacco companies, as the law tightens in this part of the world, are opening big companies, promoting employment, and at the meantime contributing to a rising tide of obesity, diabetes, cardiovascular diseases in communities that do not have the workforce. So you can see sub-Saharan Africa was the lowest expenditure in financing in health, and less than 2% of the global workforce that can tackle these challenges. So how do we change this? And there have been many important initiatives, but when you look at what we have to tackle, just looking at surgical subspecialties, gynecology, only about 17% of surgeons, are in the regions that account for about half of the world population, right? So there is a huge, huge mismatch. So for me, this was what sort of inspired my work in workforce development in Ethiopia through the Center for International Reproductive Health Training. And that was also the dialogue through Tim Johnson and Laurel and Einstein, Dr. Marquez, and several other obstetricians and gynecologists in the United States saying, how can we contribute to this? So when I came to Wisconsin about 10 years ago, and Laurel was trying to respond to junior faculty like Cynthia and several medical students and residents who traditionally would go on medical missions or would go to advance the faculty's research desire because global health had emerged as a nice quick pathway for faculty development and to entice students, but a lot of it had turned out to be more like a touristic visit where you go for a week, you take your students. In fact, you cause much more disruption to the system because you show up, they have to accommodate you, you have more resources than them, they're hoping for much more than systematically going and saying, how do I help you fundamentally transform your system in such a way I enable you to take care of your communities. But in the process, it will be a bilaterally, mutually beneficial relationship where our students and residents and faculty can benefit as well. So it was with that concept that I had put a proposal at that time to the foundation saying, can we look at large workforce development that will contribute, for me, with a particular focus on access to safe abortion and family planning. When we did that, there were two core beliefs that I tried to tackle. One of them was every woman, no matter where she lives, or every girl, and again, for me, I always put myself in this and say, what would my path would look like if I did not come to this country, right? So, but not for this, I would not be standing there. So how do I ensure in the work I do that that becomes the reality for the women and girls around the world? The other, I think, fundamental thing to notice is that unlike the US, abortion is not a political issue in most parts of the world. And where we're making it a political issue is when we export our views from this country. So how can we really work in places like Ethiopia, where there was a real burden, but how do we really tackle pervasive poverty, social inequality, and other things that disproportionately impact women through expanding services? You know, there was a fascinating World Bank report that came out that basically demonstrated, I think a couple of years ago, that countries cannot build their economies by leaving half of their population out. So for some countries, it's the right thing to do from human rights angle. For other countries, it's an economic issue. And for many, especially now what we're seeing in Francophone West Africa, it's a rights issue. So I think comprehensive first, because women have a fundamental right to access the services. But second, no matter how much access to contraception to promote women, always, we'll need abortion, right? There's this assumption that if you make contraception available, that the need for abortion will go away, and we know that that's not the case. So when we started working with SIRF, the main objective was to do two things. One was to mainstream the services, just make them as readily available as vaccines, as antenatal care, as things that don't have stigma. But the second is to really integrate it so that women don't have to go to different places for different services. If you look at our healthcare expenditure globally, and unfortunately, healthcare in the global south is mostly run by donors. But when you look at distribution, you can see since the 1990s, almost for like about 25 years, we have spent over 10 billion, greater than 10 billion funding maternal and child health to strengthen health systems, right? But if you look at of the total expenditure, it is completely siloed and vertical. This is how we spend. We'll go and we'll have a system for tuberculosis, a system for HIV/AIDS, a vehicle to tackle non-communicable diseases, but not in an integrated way. In the US, if a person shows up at a health facility, they show up to get all the services available. Depending on where the facility is, and those services are not available, if I show up in rural Wisconsin and I need debulking, I may be referred to this hospital. But in general, you don't walk into a clinic where you get, other than maybe if you are like in a very specialized clinic like Planned Parenthood, even Planned Parenthood gives a range of services for women's health. Whereas very heavily driven by donors who are particularly looking for quick results, the Global South has set up health systems that deliver for individual vertical programs. That has been quite detrimental to the population. So the greatest lesson that we are trying to learn from at the foundation is what has happened with PEPFAR, which was one of the most meaningful and largest programs the US government had funded to tackle HIV/AIDS, which was mostly neglected and put kind of aside, and basically people were getting death sentence, the treatments were very expensive, and through PEPFAR, many things happened. Drug prices were negotiated, large-scale people were trained, and services were available, and we really tackled that epidemic and saved lots of lives. However, the way we went about doing it was not through strengthening health system and training the right workforce. So what did we do in PEPFAR and other vertical programs? Large-scale programs will start, and they will do what's called in-service training in global health. What in-service training is basically, if I want to come and introduce cervical cancer screening for a group of medical students, instead of integrating that into the medical education curriculum, working with the faculty to make sure it happens recurrently, that their core competencies checked, I will take your 150 medical students to a hotel for a week, give them per diems that in fact incentivize them to just come and do these trainings, and they will get these trainings and they will come back to a clinic where there is no antiretroviral therapy, where there are no counselors, where you cannot test in confidentiality. So it was really creating chaos, and also it was completely not sustainable. So what has happened and what we're seeing now in countries like South Africa as PEPFAR is winding down is a rise back in HIV. But guess who's being impacted the most? Women and girls, right? Like the society that usually just does not, the community that doesn't sit at the table to make these decisions. So for us, it was very important when we started CERT that we were going to put women and girls at the center. It was going to be about integrated care, and it was going to be about changing the health system, changing medical education, changing nursing and midwifery education, so that someone like my daughter, Helena, if the odds of her being born was not like in the United States, but rather in Ethiopia, or Rwanda, or Madagascar, that she will have the same opportunity as you guys sitting in this room, or a person who's born somewhere else. In fact, sadly to say, the odds of a girl thriving in the United States is more jeopardized today than it is for many girls around the world. So for me, the question is, what more can you do for women, and what more can I do for women, right? You can, it's very, very easy to say, we are doing our job, right? We are women's healthcare providers. So if you look at progress in sexual and reproductive health and rights, it's really been uneven in recent years. Yes, I talked to you about some bright spots, but legality even in those countries doesn't mean access. And what better example do we have? Although it's being chipped left and right, abortion in this country is legal. But does legality equal access? And who is making decisions for women, right? So for me, there is no more appalling picture, irrespective of what we hear every day. Pictures speak 1,000 words. So every time I look at this picture, I get appalled, not just by what the executive order is all about, but who is sitting at the table making decisions for women and women's health. I mean, how can we settle for this? I frankly, Tracy and I spent a lot of time saying, do we realize what's going on? Like, how come we're not appalled? It's very easy as healthcare providers to silo ourselves and think we're really doing great stuff. We're taking care of women. But for me, it's really hard to reconcile the fact that I take care of women if I'm not reconciling this fact that as a healthcare provider, we are letting other people take charge of policy, law, all sorts of social norms, and we think we're empowered to take care of women. So it's not really shocking or surprising that we're not at the decision making, because we have not been bold enough to advocate saying, no, we should be having a conversation. Our societies have not been bold enough. Ideology has gotten and replaced science. And we have really failed to adhere the compass of scientific evidence to say, no, as scientists and as women's health advocates, this is how we're going to advocate and work for women. So, I talked about the global stuff, but look what's happening in the US, right? So if you look at, in the last 20 years, what's happening to the number of policies enacted. Look at the disproportionate number. We're getting more laws, and of course, depending what is going on politically, you see a rise, but there are constantly a lot more activity around policy and laws on things that restrict abortion and family planning than proactive policies that are supporting women. And what are we doing as healthcare providers? What are we doing as nursing societies and the midwifery society and our organizations? Frankly, I have very strong feelings about ACOG, and I think both Laurel and Doug and many of you know, but I think we talk about special interest. I think I can speak at least on behalf of gynecologists. I think our special interests for this and for that, whether it's preserving Da Vinci or making sure that our reimbursement is not declining, has really gotten in the face of what we should be doing and why we are here in the first place. And I think the fact that we're not doing harm shouldn't be measured by the complications in the operating room. I think our failure to be outraged and to stand up and to speak every day and what's happening in this country is a responsibility of all of us. And I really feel like as healthcare providers, we carry much more the brunt of the burden than, frankly, our policymakers who rely on experts to make policy. So, Tracy and Callie can speak to this. Our foundation, as anonymous as we are, have spent enormous 30 years funding and supporting workforce development so that abortion, family planning becomes an integral part of your training, medical education to a lesser extent, but residency and fellowship training. So where are the people that are trained when 90% of counties in the United States, I wish this heat map was the reverse and was telling us where women can go to access abortion. These are the places, look at this. Greater than 90% of US counties lack abortion provider. And in most parts of the world, in the country, women have to travel over 100 miles to seek abortion services. So how does that make us feel as women's health provider and women's health advocates? And for me, I literally, when we talk about the success of the foundation and we high-five each other, I cringe a little bit saying, have we really succeeded? After 30 years of investment in building a massive workforce, if that workforce is not out there advocating for women and changing this? So I don't know, how do we measure success? Is it the number of people we train? Or is this the number of people that come out and actually change the lives of women? Not sure, but I'll leave the answer for you. But really, the image is quite grim. The other tragic event is maternal mortality. I don't think I need to interpret this data for you, but look what is happening in the United States from 1987 to 2014, where the trends in pregnancy-related morbidity and mortality, this figure particularly is on mortality, but we are now looking like Mexico. We're now looking like the developing part of the world. But what's tragic is our healthcare investments are one of the highest in the world. And when you start looking at intersectional issues like race, when you look at class, when you look at economic status, the data gets even grimmer, right? Black babies are 3 times more likely to die than white babies. If you look at who dies in childbirth, it's Black women, Hispanic women, that are more likely to die in childbirth in this country than white women. So, Tracy and I struggle with this, right? While we remain staunchly, firmly committed to access to safe abortion, how do we reconcile access to safe abortion if we cannot juxtapose that with death of mothers? What does it mean to care about, right? So I think we have to speak up against this, honestly. For me, silence becomes acquiescence, and I think we have the responsibility and our failure to speak up to this ugly truth and get together in global meetings and international meetings and meetings from Nashville to San Francisco on a weekly basis for our professional societies to get together and celebrate new technologies and new tools when we have failed to prevent things that happen naturally. I am by no means discounting that we need to do robotic myomectomies or spend 10 hours repairing, that's what I did for a living, reanastomosing tubes or taking care of cancer. But if we cannot take care of the basics and our rate of maternal mortality is approaching that of the global south, in a country that has abundant resources, and it's affecting those that are the most marginalized, I think we're failing not only as a society, but I think as a profession. And I hope if you don't take anything else from this lesson, from this lecture today, you'll take the lesson that we have been watching as just grim statistics happen to communities that have no voices, that are marginalized, and we have not used our power and privilege to impact the lives of women and girls. So my hope is that today, if you don't remember anything else, that of course you all are an advocate for women and women's rights. As providers, offering the best care we can for women, that requires us to deeply understand the context in which our patients are living, in which we're providing care, and keeping our sight always. We cannot address what we're not paying attention to. We cannot correct what we're not measuring. We cannot change what we don't see. And I think we see women, tragically, I used to be so offended when I would sit there and people will come and talk about the failure of the health system or the physician, because what I do is I get up every day and contextualize it in my life, instead of seeing it within the optics of the communities and the women we take care of. The way I understand my life is how I get up at 5 o'clock or 4:30, a very hard-working physician with 4 kids, having it tough, juggling work-life balance, having to show up at 6:30 for M&M, followed by grand rounds, and then long day in the OR, in an increasingly hostile environment, spending my day documenting EPIC, followed by, you failed to evaluate residents, followed by, did you submit, I'm going to decline your travel expense because you stayed in a hotel that did not meet the administrator's requirement. You overspent your travel allowance, right? So we all have struggles. That struggle that we failed to turn in a form, we did not sign our dictations within 24 hours from OR, this bill could not be submitted, you did not check the right box. So I know practicing medicine has become a very laborious and exhausting task, but at the end of the day, it's the most remarkable profession where you are interested and trusted by communities and by women. And I think where we have failed is to focus on our daily struggles of long OR days and frustrating practice environments, and failing to prioritize what to focus on. So I think we've shifted the focus from the communities, the disparaging experience women go through, to our own inconvenience in practicing medicine in this country. So my call to action would be for you to really wake up and pay attention to the system. You are already doing incredible work in an environment that is really prevailing, with prevailing forces that are working against us, undermining women's rights and well-being every day. But the question is, how do we do more? How do we do more effectively, more compassionately, more boldly? And among us, you are incredible physicians who get up and do that every day. You cannot ask for a better leader than Laurel Rice. When asked as a GYN oncologist, and I will be pretending if you don't know the hierarchy within obstetrics and gynecology, where we've taken the pelvis and divided it into 7 or 8 subspecialties. And as a GYN oncologist, she sit top, right? But the first time I met her in a very Laurel way, she was sitting with her legs crossed and telling a group of surgeons she proudly does abortion. That's what she does. She takes care of women. So especially at Wisconsin, you have no excuse to not be that, to not be Laurel, to not get up every day and advocate for women. You have Doug Lobby, who has done it all, right? Like he could be retiring in Hawaii or in Mexico. But last week, when President Trump came about 100 or so miles from where you are today, and got in the room and talked about how doctors and women conspire to execute babies, it was Doug who got up. It was not ACOG. ACOG made a very cute statement, but it was Doug who held a press conference and made a statement how appalling that is, how that is not scientific, how we are outraged for women. how we are outraged for healthcare providers whose life is now going to be at a much greater risk, like those providers in Syria who get bombed, like those providers in Democratic Republic of Congo who get gunned down when they provide care for Ebola. So where is our voice? Who is writing the op-eds? Who's afraid? We can't expect someone else to do it for us. So for me, again, the call to action is to leave your voice and really not underestimate the immense power that's been bestowed upon you as physicians in this community. The immense respect you get when you speak. And really, instead of just speaking when we are outraged about pay for performance, when we are outraged about increasing restrictive environment, or the complaint about the 80-hour work week that's taking our residents away, making them lazy, all sorts of things we complain about. Really take this as a task. Frankly, if the nurses and the midwives and the doctors are not going to speak up for women, I don't know who else will. And I think here, particularly in Wisconsin, places like Wisconsin, Michigan, San Francisco, Berkeley, great public institutions that have really transformed this nation, who have marched out for civil rights, who have marched out for LGBT rights, somehow are not marching out for abortion rights. And I think my call to action is for all of you to give this a serious thought and take your immense privilege and advocate for women's rights. I believe that gives us a moral imperative to not only do no harm, but to see our voices, our platform, our privilege, that we can help in the face of these large forces that are undermining women's health and rights. I really think we're facing an urgent crisis on reproductive health and rights worldwide, but the culprit is the United States. We are making immense progress, particularly Sub-Saharan Africa, particularly Francophone West Africa. Literally, in the last 4 years, we've had 5, 6, 7 countries that have legalized abortion, that have said we're going to address access to safe abortion, reproductive rights, reproductive autonomy as human rights. But what happens is U.S. using its big force and donor money and resources and evangelical TV stations, and carrot and stick is dangling their money, saying, if you do this, you're not going to be able to build roads. If you do this, we're going to cut your funding for infrastructure. If you do this, we're not going to support your governance and education reform. And unfortunately, governments and NGOs find themselves in this precarious situation where it becomes a zero-sum game. Do they advocate for access for abortion and then lose facilities where more number of women will die from stroke and malaria and hemorrhage? Or do they keep silent? So you cannot underestimate the enormous influence this country plays and the role you, both as individuals and collectively as a profession, can play. And I think I would put this call, frankly, as much to the medical students who are going to be the providers tomorrow. As you go through your career path, I know abortion services have not been glamorized in this country, but I always say to people, if you're going to choose one field and one field alone that's going to make the most remarkable impact at scale, it's making reproductive health services available to women and girls across the world. So with that, I will stop. I will give us about 5-10 minutes for questions before I bolt out the door to head to the airport. So thank you for that.
Yeah, hold on. So if that wasn't a call to arms, what is? Let's just take a moment here and drink in this talk, because we each do have a responsibility. And the fact of the matter is, we're stymied by all the things that Senait talked about, but we're also stymied because the University of Wisconsin is a public institution. So we have to be crafty and nimble and strategic, always looking for that opportunity. And don't think I don't think about that every day. So, questions? Oh my God, they're quiet. Come on, give it to me. I have a question. Wait, no. Oh, group is white. Oh, good God. Here you go.
Thank you so much, Senait. This was remarkable. I am not a physician. I'm an engineer, but women issue is everybody's issue. And we came from the same country. My first exposure to abortion was when I was a teenager. My mother, whose daughter died through abortion complication, teen pregnant, and came to me when I was, I think, 15 or 14 or 15, and told me about her. And I want you alive, so tell me if you have anything like that. Don't do anything, to go do unsafe abortion. So whenever I hear this talk about, restricting access for women, for a safe abortion, that rings in my mind. And I will chime in to, it's really remarkable to hear your passion for this, for all of the providers to think about any mother or father would choose his daughter to live than die because of unsafe abortion.
Thank you.
Thank you for sharing that remarkable story. And I think, if you don't mind me saying a word or two, it's really moving for me to hear that because I'm hearing an echo. Can you hear me okay? Yeah. It's really remarkable for me to hear you say that Rahel is a spouse of, she's a remarkable woman in her own right, an engineer who's doing incredible work around road safety and stunting and nutrition and connecting Ethiopia and Michigan, and I'm really grateful you came, first of all, early in the morning. But two, I've always perceived you and your husband as very religious and very, very religious people, and it just goes to show you, we've never had the abortion discussion, but it's amazing how religion has become a tool in this country to restrict women, to harm women, to limit women, and at the end of the day, at the core of it is misogyny, and the core of it is patriarchy, and it is much more significant for me that you make this comment because it is really religious people who are propagating this misogynistic approach against women. So really, thank you for that comment and sharing your personal story.
I just want to make a comment about the word misogyny, which I use frequently. Between that, abortion, and racism, those are my three favorite words to use in public. So I do think that this maternal mortality rate and the decrease in access to abortion is the best representation of misogyny in this country and in the world. Straight up misogyny. Does somebody have their hand up? Ahmed.
Thank you for the I just have a general question looking at globally and the prospect of actually developing programs for women globally. Do you think the challenges globally, and I don't restrict it here to but globally, do you think the challenges are morality and issues or just finances?
That's a very good question, right? Like, what is preventing women from accessing the services? Is it because if we were to develop programs globally? So I think, I would say morality less and primarily access, because what we're seeing in many countries is that even when there is morality, even when there are religious groups, when you make services available and you meaningfully train people and you change culture, we see a significant improvement in access and a decline in mortality. The other thing is when you have people who are, so in the US, it's an ideological war, right? It is deeply political, it is much more than saving lives, although in the South, in the Memphis and other places, Mississippi, where we're seeing black women dying, it has a much more complex element. But in many parts of the world where women die because they are also dying in childbirth, the community welcomes any intervention where you are preventing different things. So I think one of the things we're revising in our programming is that we are not siloing abortion so that it just gets targeted. So it is part of a comprehensive women's care so that a woman who comes for safe abortion can also come for antenatal care. Because one, we lose our credibility in communities when we go and say, we care only about abortion and other things. The reason why we stay laser focused on the abortion issue is that many are not. And it's almost like it doesn't matter, you cannot become complacent thinking you're making progress. But having said that, the integration is very important, and I think you will be very successful despite the challenges. And we're also seeing that because people don't look at it as a political issue, we're having religious groups, communities, once you engage and get the community's trust and they see what is happening, that's why we're making much more progress in the US than we're here. But although it's complex, the simplest answer is I think programming, resources, integrated services will lead to a much more successful outcome and are not prevented by morality.
We have time for one more question, then it's all about the airport. Yep, more.
So I have a question about medical student curriculum, because I think you bring up a good point that early exposure to the fact that abortion services are just part of caring for people is important. And I'm wondering, at Michigan, if you do anything to sort of integrate medical students, not just the ones who are interested in abortion care, because those medical students are so happy to be involved, but the ones who know nothing about it, how you can get them sort of to feel more comfortable or just learning about the services. I think oftentimes when we have abortions or second trimester abortions, we sort of say like, oh, which medical student feels comfortable into this? And I wish we did something different, saying, hey, this is part of caring for women, so put your gloves on and come on in and see that this is part of life. And I was wondering if you guys do anything at Michigan to integrate that more.
So you're nailing, right, like the tragedy about abortion training and services in this country. I mean, first of all, we don't legislate any other organ in the body other than the uterus, and maybe like embryos. And secondly, it is sort of like that opt out, opt in, who's interested, who's not interested, right? Like when you're learning about your Whipple, you don't get permission about, are you interested in Whipple or not, right? Are you interested in pelvic exempt or not? It's not an option. And abortion is not, but it's a much deeper issue around not only its absence in curriculum, but what you can do using federal funding in hospitals, and it gets very complicated. Tracy and maybe Kathy, in fact, who heads our US programs, especially the focus workforce, I would love for her to comment. Globally, that's what we're doing. We basically are integrating it into medical education, and in some countries at school level and other countries at the Ministry of Health level. So that's part of the national curriculum because professionalization starts very early. So if people are sort of picking and choosing, and you also can only do what you know and what you're modeled to do. So we're trying to work. In fact, I was having conversation with the lobby yesterday saying, I want you to go work in Ethiopia because they see gray-haired white men doing debulking and not abortion. Because modeling matters, right? Like you want to be that person that you respect, and the people that you respect and you look at role models are doing Da Vinci and debulking and pelvic reconstruction and not abortion. You're going to think abortion is something that is left for the not so good or the average or the disgruntled or whatever it is. So I think there is a lot we can do in this country to improve that. And Callie, if you don't mind commenting about what we're doing in the US.
Sure. So we do a lot in the US in this space. I think that some of the biggest things that we've learned over the years is we need a bottom-up and a top-down approach. It doesn't really work to kind of start trying to get it into the middle. And so as students and residents, you guys are really powerful. Where we've seen the most luck in taking up curriculum or requiring, we call them opt-out rotations instead of opt-in rotations, like at Ryan programs, which you guys have here, things like that. That pressure from students and residents to do it is what pressures the faculty to let you do it, right? And to keep it part of the curriculum. When you're happy with that, make sure you tell them. Make sure you tell them how much you appreciate that as being part of your education. When you're on the interview trail for fellowship, for residency, anything, ask about it. And ask about it clearly because they are listening. And I can't tell you the number of residency training programs that have added integrated abortion training because they're like, well, all the medical students keep asking us about it, so I guess we kind of have to do this, right? Even if they don't want to. So the other way is top-down. Doug Lauby here, I think, is one of the probably best examples of someone who works in this space. The CREOG exam obviously is something that is, deep in all of your hearts, whether you love it or hate it. But doctors like Dr. Levy have fought to put questions about abortion on those exams, questions about abortion on the ABOG exam. Those are ways that you can ensure that every medical student and resident will start to learn about those things. Once those are questions on exams that they are required to know, they're going to have to start learning about it. And so I would deeply encourage all of you as you move into your careers, or whether you're in your careers already, get involved with the Wisconsin Medical Association, get into leadership positions at ACOG, work on ACOG committees. That's where these policies are made. And then, eventually work your way up and, try to get onto TRRC, make more requirements about abortion and medical training. Hold them to their requirement that all OB-GYN residents learn how to do abortion, since we all know that that is not something that actually happens on the ground. It's a policy, but they don't enforce it. And so you guys are the group that get to pressure them to enforce it. And remember, as you continue, organizations like ACOG, organizations like ASRM, et cetera, they won't exist without members, right? They need you guys to exist. And so you guys have a say in what those organizations do, how they react to issues like this, whether they issue statements. ACOG, I think, has made huge changes in part to people like Laurel and Doug in the last 10 years, and that's taken a long time. And now they will come out with statements about abortion, and those statements are much stronger than they used to be. And you know why? Because instead of hate mail, they started getting love mail about it, right? Because when last time they did it, and even 5 years ago, they get a whole bunch of emails from anti-choicers threatening their memberships, et cetera, saying, this is not my organization, et cetera. Now, everybody on the other side has started realizing that they need to give ACOG positive feedback about those things, and that really makes a huge difference. Once they get to start, they rarely get positive feedback from their members about anything. So shooting them a quick email saying, I really appreciate you took this stance as a student member, as a resident member, as a regular fellow, whatever it is, those things make a big difference too. But anybody who is interested in doing more than happy to chat afterwards too.
Thank you so
You
much.
know what, we're done, because she's got to go to the airport. One comment for the medical students. We have a wonderful dean. We have a complicated state institution. So we have to be nimble and crafty and honest, of course, but nimble and crafty. Did you say something?
Yeah, I think I'll just finish by saying two things. So the ideal state, right? So the ideal state is where you're not advocating to have a routine service being included into your curriculum, but it is going to take your advocacy to get there. So really staying at it for the course until we reach the ideal state. And the second is, in my opinion, in my humble opinion, ACOG should be sticking to the compass of scientific evidence, and not whether they get a love note or a hate note. But right now, it is how it operates. If the Da Vinci intuitive people, through their lobbying power, get to them, we get a committee opinion that says Da Vinci is the standard of care when a uterus can be taken through a vaginous. So I really do have a core, like a deep fundamental problem in our professional societies on how they behave, and the ideal state, the second ideal state, is that we'll get to a world where our professional societies are adhering to science and evidence and not to emotions and how we treat them. So with that, thank you for the opportunity.